Justice systems sit at a junction where addiction, public order, and public health meet. The decisions made at first contact, during prosecution, in courtrooms, within custody, and at release can either increase harm or reduce it. When addiction is treated as a moral offense or as a property of a drug, systems rely on punishment to create change, and then observe that change does not appear. When addiction is treated as a human condition that intersects with housing, work, family, and health, justice systems become stabilizing bridges. The aim is not leniency for its own sake. The aim is safety, survival, and the gradual replacement of crisis with routine. A practical approach begins at the point of contact. Patrol officers encounter public intoxication, possession for personal use, shoplifting tied to withdrawal, and disorder linked to untreated mental illness. Two paths are available. One path books the individual, starts a chain of court dates and missed work, imposes fines and fees that cannot be paid, and adds a criminal record that reduces housing and employment options. The other path deflects eligible cases to services at the scene or within hours. A clinic that can start medication the same day, a shelter bed, a case manager who can arrange identification documents and transportation, or a crisis team that can de-escalate and plan. Deflection requires policies that authorize officers to choose the second path, training that makes the choice credible, and partnerships that make the handoff real rather than rhetorical. Diversion in the prosecutor's office continues this logic. Many jurisdictions have relied on charge and supervise models that demand perfect compliance and punish lapses with jail. Outcomes improve when diversion emphasizes rapid entry to treatment, acceptance of evidence-based medications, and measured responses to setbacks. Eligibility criteria should include the people at highest risk rather than only those easiest to serve. Conditions should be specific, realistic, and linked to health. Appointments kept, medication taken as prescribed, housing secured, school or work attended. Dismissal upon completion protects future employment and housing prospects. If diversion fails, consequences should be proportional and should preserve access to care. Courts that adopt problem-solving practices can avoid the trap of turning treatment into another theater of punishment. Sanctions have a role, but they must be calibrated. Automatic incarceration for a single missed appointment undermines the stability that treatment is designed to build. Graduated responses, brief and certain rather than severe and unpredictable, keep individuals engaged. Incentives matter as well. Recognition for milestones achieved, 30 days of attendance, completion of a training module, securing a lease, reinforces the behaviors that reduce recidivism. Courts must also ensure that medications for opioid and alcohol use disorder are available without prejudice. Prohibitions on these medications in the name of purity violate clinical standards and increase mortality. Inside jails and prisons, policy choices carry life and death consequences. Abrupt withdrawal from alcohol or benzodiazepines can be fatal. Unmanaged opioid withdrawal drives desperation and creates immediate risk on release. Facilities should screen on intake for substance use, pregnancy, mental health conditions, and infectious disease. They should initiate or continue medications for opioid use disorder, manage alcohol and benzodiazepine withdrawal with standardized protocols, and treat depression, anxiety, and psychosis. Pregnant patients require integrated care and maintenance therapy. Infectious disease testing and treatment should be routine, including hepatitis C and HIV care. Wound care, dental services, and vaccination reduce the complications that drive hospital transfers and costs. Release planning often begins too late or not at all. Overdose risk spikes in the weeks after release, when tolerance has declined and contaminated supply is common. Effective programs start at least 30 days before release. Identification documents are secured. Insurance is activated. Appointments are scheduled at precise times. Transportation is arranged. Bridge prescriptions are provided. Naloxone is placed in hand, along with simple instructions. And a named person from the receiving clinic meets the individual at the gate or at a designated transport point. Without these steps, plans collapse into good intentions and avoidable funerals. Housing sits at the center of successful reentry. A person without a stable place to sleep will struggle to store medications, attend appointments, keep work or training schedules, and avoid high-risk settings. Housing first models reduce death and emergency service use, even when abstinence is not immediate. Recovery housing supports others who prefer substance-free environments. Oversight prevents exploitation and aligns house rules with evidence rather than ideology. Public housing authorities can adopt fair chance policies that evaluate applicants individually, rather than imposing blanket exclusions for drug-related records. Landlords can be engaged through mediation, risk mitigation funds, and clear behavioral agreements that distinguish relapse from violence or property damage. Employment translates stabilization into trajectory. Background checks and categorical bans keep qualified workers idle and increase the likelihood of return to illicit markets. Fair chance hiring policies, certificates of rehabilitation, and employer partnerships with treatment providers create on-ramps. Supported employment models place individuals quickly and provide coaching that follows the worker into the workplace, solving problems that would otherwise trigger resignation or termination. Apprenticeships and short-cycle credentials aligned with clinic schedules reduce conflict between treatment and work. Employers benefit from reduced turnover. Communities benefit from reduced recidivism and increased tax revenue. Fines and fees accumulate quietly into barriers. Court costs, supervision fees, mandatory program payments, and driver's license suspensions for unrelated debt trap people in cycles of non-compliance. Systems that review and consolidate debt, convert it to community service where appropriate, and restore licenses when public safety permits, remove obstacles to employment and treatment. Legal clinics embedded in reentry programs can address warrants, expungement, family law, and identity theft. When legal issues are handled in silos, a missed court date in one case can undo months of progress in another. Probation and parole conditions require careful design. Requirements that outstrip daily capacity set people up to fail. A person attending clinic 3 mornings per week and working an afternoon shift cannot also report twice weekly at unpredictable times. Conditions should be specific, necessary, and directly related to safety and recovery. Access to medications must be protected. Drug testing should be purposeful rather than reflexive, with results used to adjust care rather than to trigger automatic incarceration. Graduated responses to violations preserve dignity while enforcing boundaries. The most successful supervision officers operate as connectors to services rather than as monitors alone. Public order and compassion are not opposites. Residents and businesses have legitimate concerns about disorder in public spaces. Responses that rely solely on displacement move risk into alleys and bathrooms where death is more likely. Responses that combine enforcement against violence and exploitation with visible services, supervised consumption where authorized, outreach teams with oxygen and naloxone, housing navigators, and mobile clinics reduce public use in syringe litter while saving lives. Municipal codes can be revised to focus on behaviors that threaten safety rather than on survival behaviors that can be redirected by services. Communication with neighborhood groups should be regular, specific, and oriented toward metrics. Fewer overdoses in restrooms. Fewer emergency calls linked to the same locations. More people entering treatment. Data and measurement prevent drift. Agencies frequently maintain separate systems that cannot see one another. Emergency services track overdose calls. Hospitals track admissions. Corrections track bookings and releases. Clinics track intakes. Housing agencies track leases and losses. Integrated dashboards that protect privacy while sharing essential signals allow real-time adjustments. If overdoses rise in a particular corridor, outreach can surge there this week, not next quarter. If releases peak on Fridays without weekend clinic access, schedules can change. If housing losses cluster after 30 days, supports can be extended through that window. Metrics should include access to medication within 48 hours of release, retention at 30 and 90 days, housing stability, employment, emergency department utilization, infections detected and treated, and rearrest and reincarceration rates. Disaggregation by age, gender, race, and geography reveals inequities that demand correction. Equity matters at every step. Neighborhoods with fewer clinics and more patrols will show different arrest and treatment patterns than neighborhoods with the opposite configuration. Language access affects engagement. Women encounter different risks and responsibilities than men, especially during pregnancy and postpartum. LGBTQ+ individuals face stigma and violence that deter help seeking. People with disabilities require accommodations that are often absent. Equity reviews should be scheduled, public, and tied to changes in siting, staffing, training, and contracting. Unequal systems produce unequal outcomes. Acknowledging this is the first step toward repair. Ethics and rights are not add-ons. They are the foundation. Consent must be comprehensible. Privacy protections must be respected while enabling coordinated care through appropriate consents and data sharing agreements. Withholding medications as punishment violates clinical standards and increases risk of death. Involuntary holds should be used sparingly and paired with rapid transition to voluntary care once imminent danger passes. Pregnant patients deserve non-punitive pathways that protect infant health and family stability. Pain management should not be denied because of an addiction history. Families should be offered participation in planning when appropriate, with clear boundaries to protect safety and autonomy. Technology can reduce friction when used with discipline. Electronic records in jails and prisons should interface with community clinics to permit seamless continuation of care. Telemedicine can expand access to counseling and medication management both inside facilities and after release, reducing missed appointments for individuals balancing work, caregiving, and transportation barriers. Secure messaging between supervision officers and clinics can replace redundant appointments and allow quick confirmation of attendance. Appointment reminders, ride vouchers, and digital identification cards can prevent minor obstacles from derailing plans. Financing signals priorities. For decades, budgets have favored enforcement capacity over clinic capacity. Rebalancing does not eliminate the need for law enforcement. It ensures that health responses exist when enforcement is unnecessary or counterproductive. Contracts can tie a portion of payment to outcomes such as medication initiation within 48 hours of arrest or release, retention at 90 days, reductions in emergency department utilization, housing stability, and employment. Risk adjustment prevents providers from avoiding high-acuity cases. Settlement funds and appropriations can seed housing with on-site services and support mobile outreach staffed by clinicians and peers. Governance prevents drift back to rhetoric. Interagency councils that include health, housing, justice, education, labor, and community organizations should meet on a schedule, publish minutes, and maintain dashboards. Conflicts about jurisdiction and budget should be resolved by reference to shared goals. Fewer deaths, fewer infections, fewer assaults, more stable housing, more employment, and safer public spaces. Leadership should model clarity and humility, acknowledge trade-offs, and adjust quickly when data indicate failure. Communities that rely on press conferences rather than on dashboards repeat errors because attention moves faster than implementation. Practical blueprints allow faster starts. A 90-day sprint can establish on-site medication initiation in jails, create release day handoffs with transportation and bridge prescriptions, saturate high-risk corridors with naloxone and oxygen through outreach teams, implement deflection protocols for patrol officers, and publish a simple referral number that routes calls to the right provider. A 6-month plan can add housing units with on-site services, expand clinic hours into evenings and weekends, standardize probation and parole conditions to protect access to medications, and train court staff in graduated responses and incentives. A 1-year plan can integrate data systems, evaluate performance publicly, and adjust contracting to reward providers that meet targets and to replace providers that do not. Details decide outcomes. Walk-in clinics must actually be open during posted hours, including the hours when release buses arrive. Jails must stock medications and maintain prescriber coverage so that intakes on Friday night are not left untreated until Monday. Probation check-ins must align with work schedules and dosing windows. Public defenders must be able to reach clinicians rapidly to craft diversion plans before arraignment. Hospitals must treat infections fully and hand patients directly to community teams rather than discharging with instructions alone. Shelters must have staff trained in overdose response and de-escalation. Outreach vans must carry wound care supplies, hydration, naloxone, and drug-checking tools where lawful. When these details are neglected, systems revert to crisis management. When they are handled, systems look like quiet competence. Public communication should replace spectacle with service. Announcements should include clinic addresses, hours, and transportation options. Explain how to obtain medications and naloxone, clarify Good Samaritan protections, and provide hotlines answered by trained staff. Alerts about dangerous supply should use plain language and offer immediate steps that reduce risk. Media coverage should avoid images that exploit suffering and should highlight successful programs and routines that reduce death and disorder. Residents respond better to information that tells them what can be done than to declarations of war. Special populations deserve explicit planning. Adolescents require confidentiality and developmentally appropriate services that involve families without criminalizing experimentation. Pregnant individuals require integrated obstetric and addiction care and protection from punitive reflexes that deter prenatal care. Older adults require attention to polypharmacy, fall risk, and grief. Individuals with serious mental illness require coordinated care plans that align psychiatry, primary care, housing, and supervision. People returning from long sentences require gradual reintroduction to technology, transportation, and employment. Veterans require coordination with benefits systems and trauma-informed care. Each group needs predictable doors to walk through and staff who understand their specific risks. The relationship between enforcement and health is not zero-sum when roles are clear. Enforcement focuses on violence, coercion, corruption, and trafficking. Health focuses on survival, stabilization, and recovery. In communities where these roles are aligned and respectful, violent crime falls and overdose deaths fall together. In communities where enforcement substitutes for health, jails fill and funerals continue. Metrics make this visible. Budgets make it changeable. Addiction is a human condition. Justice systems that accept this premise design responses that reflect it. They expect ambivalence and plan for it. They protect access to medications and measure whether that protection is real. They treat relapse as a signal to adjust care rather than as a moral verdict that cancels housing, employment, or family life. They reserve punishment for conduct that threatens safety and use every other lever to stabilize and integrate. The result is not utopia. The result is fewer deaths, fewer assaults, more ordinary days, and neighborhoods where emergency sirens sound less often because the conditions that produce the crisis are being addressed with competence rather than with slogans. The path forward is repetitive work executed reliably. Officers offer deflection rather than default arrests. Prosecutors prioritize diversion that begins treatment, rather than punishment that interrupts it. Courts calibrate responses and protect medications. Jails and prisons initiate and continue care and hand people to clinics with transportation and prescriptions. Housing authorities adopt fair chance policies and coordinate with case managers. Employers hire with support rather than fear. Dashboards update. Budgets follow results. Families receive tools. The community watches numbers move in the right direction and trusts the institutions that made it happen. In this arrangement, justice and health share the same definition of success. Fewer preventable deaths, fewer preventable crimes, more stable housing, more employment, more children raised by parents who are present and steady, and public spaces that feel safe because they are used by neighbors rather than abandoned to crisis. That is a serious objective that requires serious methods. It does not require new rhetoric. It requires routines that work and an insistence on measuring whether they are in place. Where they are, the human condition that makes addiction possible is met with structures that make recovery possible. Where they are not, the signs are already visible. The corrective is known. The task is to build it and to keep building it until crisis is the exception again.